this physical appearance. This is what is important to me as a person and to preserve my dignity in these moments. And I think it goes without saying in all of this that trans folks may be especially vulnerable at end of life to this misgendering, misnaming, dead naming. It also goes without saying, and I think we've touched on this a few times before, that when we think about nursing homes or post-acute and long-term care facilities in general, there's really strong evidence out there that shows that older lesbians and gay men especially have historically delayed entering these places, worrying about stigma, discrimination, worrying about being forced back into the closet. I hear that a lot from my patients as they even think about this. I hear it from my parents who are cisgender lesbians about how will I be able to live as myself in a facility one day, maybe, where most people are not going to understand and may not even be accepting. So this is a heavy topic for the moment, and it can be. But what I'm saying here is that when I think about talking to my LGBTQ folks especially, I really focus on advanced care planning in these primary care visits and in general. It is so important that everyone in this room have a surrogate decision maker named. What does that mean? That is the person who makes decisions for you in the event that you cannot. Medical folks are always going to try to rely on you as individuals to make your own decisions. And there is no blanket statement that says, Michael cannot make any decisions. It can fluctuate. But if they find in a moment that I am too confused, they need to look to my surrogate decision maker. And that is the most important part. I think it's really important as we frame this to talk about how do we respect sexual orientation and gender identity as we document this, whether it's names, pronouns, or appearance and values. The identity as a whole needs to be reflected in documents like this. And last, we need to be very active about combating this idea of feeling forced back into the closet. I think as a lot of folks here sadly probably know, medicine can sometimes feel a little dehumanizing or a lot dehumanizing. And so as disease processes age, I deal with this a lot with folks with dementia. The reality being that folks' experiences are changing, but we still need to be true to who they are as people as we care for them. And so what we're going to talk about today and what we're going to review is going to be really helpful for all of this. Now, here's some data that's, this gets a little nitpicky. I'm not going to go through every statistic. Only 1 in 10 LGBTQ folks studied back in 2017 had actually discussed advanced care planning with their primary care doctors. And the scary part is that 92% of those 1/10 brought it up themselves, meaning no one is asking. And so you don't need to kind of raise a hand, but I would ask folks to think about how many people have been asked about this. And I think we're getting better at this year by year. So my hope is that the answer is most of you have been asked about this. Maybe I'm wrong. Again, as we know, transgender folks are at risk here, and they actually have, from the data, the lowest prevalence of legal documentation for end-of-life care, which really scares me. Because these are the folks, not that everyone here isn't vulnerable in some way, but especially our trans folks, there's a lot that can be lost here. It's always easy in these talks to go through and say, well, everything looks terrible, because there's a lot out there that can be. I want to look at this last part right here where I'm kind of highlighting my mouse. I think you can see that. Oh, maybe not. These last two down here, appointing a healthcare proxy. Studies really vary, and this one compares the general population, which I hate that word, to LGBTQ folks in general. And it says here that LGBTQ folks are doing this more. They are appointing someone legally more than the general population. And that's what I want to see. I want to see all my patients doing this document. And those who see me know that I harass them about it in a nice way. So any questions about the background? We're going to go into the how, we're going to go into the what soon. Right. So the question now becomes, you'll hear the term ACP or advanced care planning. You'll get documents, you'll get asked, have you done advanced care planning? And if I ask someone that, a lot of the times I get the question, well, what the hell is it? So that's a fair thing. Nothing in healthcare is perfect. Nothing in this country is perfect. But we have ways to approach planning for the future despite that. I brought for everyone here, as I said, this document called the 5 Wishes. This was assembled by a federal group that makes this available to healthcare systems and patients, fortunately free of charge. But Pennsylvania also has its own advanced directive form. And when I think about advanced care planning, there are really 2 ends to this. One is this idea of naming a medical decision maker, which I've already gone on and on about. The other is the idea of actually doing what is called a living will of some kind. A living will actually goes through and defines certain healthcare choices that people would or would not want. I have some folks, when I bring this up to me, for instance, who say, the idea of ever being on a ventilator is something I would not want. And there are ways in this document and others to specifically say, under no circumstances ever. So you have your surrogate decision maker, you have your living will. Oftentimes documents combine these. So the 5 Wishes combines elements of both of these. The Pennsylvania Advanced Directive form, which I didn't bring today because it's kind of cumbersome, also does both. We're going to talk about which of those I think are most important for most people. 5 Wishes gets really into the weeds. So this document, we'll go through what the wishes are for those who don't have it in front of them. But this document starts out with surrogate decision making. And by the end, we are getting into types of care that I would want, how comfortable I would want to be if I were nearing end of life, the things I want my loved ones to know. Some people feel it's a little hokey, I admit that, but it can be really helpful. There's this new model too, whoops, I just went way ahead, called patient priorities care. It's something that geriatric medicine is really trying to, 1, wrap its head around, and 2, be better at embracing. Anyone who's been to a doctor's visit recently knows that there are often 2 agendas in the room. One is what you all are bringing. The other is when I look at a patient's list and I see blood pressure that's through the roof, diabetes that's uncontrolled. So the priorities don't always line up. And this new model really tries to align that for folks who are over 55 and say, look, these things, all of these things are important. The screenings, the medical treatment, the medications, but we're not going to get anywhere unless we have the patients on board. We're not going to get anywhere productive unless the primary focus of our visit is brought to us by the patients. And so as we think about this in advanced care planning,
102 trolley schedule from Sharon Hill to 69th Street.
I think someone's not muted out there.
These results.
Bill, we hear you. Will Gordon, we hear you. Here we go.
Thanks, Mark. I couldn't see who was talking, but I appreciate it. So the idea being that we should in healthcare be shifting more toward priorities that are being brought into us. And I think that's especially important when we think about end of life or serious illness. So I mentioned earlier, how can we make these advanced directives affirming, or how can we really use them to protect people's sexual orientation and gender identity? The National Resource Center on LGBT Aging has a ton of great documents for both patients and providers. And so this is an example of their affirming advanced directive that focuses on name, pronouns, and appearance. And it's very clear. If that's something that folks want to go through, what I will do is I will actually print this off and I will stick it into their 5 Wishes document and staple it on. That's allowed. As I said, the disposition of bodily remains is also a big issue. New Jersey's documentation has this built in. Pennsylvania's does not. So what this will say is this will protect the same things and it will name the person, who's often the same as that power of attorney, to actually make decisions after death. Questions about the how? Or comments on the how? Yes. Great question. So the question was, is the 5 wishes a legally binding document? And the answer is yes, in all but 5 states, which are listed in the front: Indiana, Kansas, 6 states, sorry. Indiana, Kansas, New Hampshire, Oregon, or Texas, or Ohio. So when we go through this, we'll look. The last page of this is the signature and witness statement. So this document is considered legally valid and accepted in the states of Pennsylvania, New Jersey, and Delaware, New York, etc., as long as it's signed and witnessed by 2 other people. The only things are, it can't be the healthcare provider, or it shouldn't be. But in a group like this, or in a setting like William Way, I'd be hopeful that people would be able to even use the community here as a way to do that. In those 6 states I mentioned, this document can still be accepted as long as it's notarized. So this does not need to be notarized. You do not need a lawyer to do this. Caveat to that being, this is all about advanced care planning for the medical side. Sometimes I get questions about financial stuff, and admittedly, that is not something that we in healthcare do because we're not legally allowed to. That's something where you do need a lawyer for the financial side of things, because they are usually the same person, but not always. Other questions or commentary?
For people who have like Jefferson My Charts,
Mhm.
can these documents be uploaded to the My Chart so that everyone has access to them?
Wonderful question. So yes, so these sorts of documents, the question was, for those who have My Chart or my Jeff chart, my pen chart, can these be uploaded? Yes. So if a patient gives me a document or sends it in via the portal, I file it in the chart as an advanced care document. And what it will say, anytime someone gets admitted to the hospital or has a visit, underneath the name and kind of identifying information, a little banner will say has advanced care docs. And I can tell you, as somebody who does inpatient palliative care, when somebody has that and we're facing situations of uncertainty, it is amazing, because these documents tell us not just who that person is, but hopefully how do we find them. So yes, to answer your question, it is reflected.
It's also Penn as well as Jeff.
So yes, so any health system, Penn, Jeff, Temple, wherever you go will accept this. This particular one has Jeff's logo on the back. It doesn't matter. They're all the same document. That's just Jefferson's kind of stellar marketing there. So advanced care planning sounds great. You know, you would think that everyone would be really pushing this. Interestingly enough, one of the biggest leaders in geriatric medicine and palliative care in the United States, who is also the head of the division at Mount Sinai in New York, basically says advanced care planning is easy, it's clear, and it's a huge waste of time. So why? His argument is not that we shouldn't be having discussions. His argument is that some aspects of advanced care planning and documenting relies really hard on things being black or white. If I'm dying, I do not want this. If I cannot eat, I do not want a feeding tube, or I do want a feeding tube. The reality of everything in medicine, or most things in medicine, is most things are not black and white, they're in the gray area. People like to think of things, or people tend to think of things, not like. People tend to think of things as, I want you to do X, Y, or Z until it's clear that I will die. The reality is, as a palliative care doctor, as a hospitalist, I can't tell you necessarily that this is you're going to live or die. You might be somewhere in the middle where things look really different than they did before. Sorry, this is a heavy topic. I should have given the caveat there. Here are some of the gray areas in the Pennsylvania Advanced Care Planning document that I didn't bring today. If I'm so sick that I may die soon, what would I want as far as life support treatments? This document's problematic for a few reasons, because I want to stay on life support machines even if I'm suffering is a pretty dramatic statement. As a palliative care doctor, I never use the word suffering with patients because I'm pretty sure everyone in this room might have a different idea of what suffering is. The question becomes when we move to the second one. I would be okay trying it, but I don't want to stay on life support. If I am suffering, I want to stop. And then it becomes the challenge of who defines when that point is. Someone who's filled out this document has gone through and said, hey, I'm willing to give it a go, so to speak, but where does that line get drawn? And then at the bottom, this is the box that I actually like the best. I want my medical decision maker to decide for me. Because even Sean Morrison, even that guy from Mount Sinai, who I respect a lot, one thing that he will agree with is that the most important part as we think about advanced care planning is finding and naming a surrogate decision maker if it is at all possible. Even if it's someone you're not related to, even if it's someone who you've only known for a few years, someone who you can have a true conversation with about wishes, preferences, values. That is by far the most important part of the 5 wishes document. It is wish number 1 for a reason. And the reality is you can fill out the 5 wishes and only do wish 1. That's fine. Questions about any of this? I want to wrap up here with my kind of speaking part before we get to some discussion and actually letting people look through the documents. Just talking a little bit about what does serious illness mean? What does end of life mean? What does palliative care and hospice entail? Because I think this is one of the things that I probably see misunderstood the most from just general, including among healthcare providers. So serious illness, I'm going to start with that before I go to this. A serious illness is anything that has the potential to be life-limiting. Meaning, there are probably people in this room, and you don't need to tell me, but there are probably people in this room who have heart failure. Heart failure, when it's well managed, can live for decades. Heart failure, when it reaches a certain point, can be considered life-limiting. There are multiple conditions, such as a variety of cancers, that may be considered life-limiting. When we start to think of, and when I use the term end of life, I tend to think of folks who we can reasonably estimate from the medical side to have around 6 months or less of prognosis. We are not perfect at determining prognosis. I will say that. We use best estimates based on available medical data, based on what we call functional status, how people are doing with walking around, getting to their appointments, how they are doing with managing the things in their day-to-day life that they need to do. I don't use the phrase, I don't have a crystal ball, but I'm going to use it right now. I do not have a crystal ball. I can pull up data from a variety of medical conditions, and I can tell you that the average survival for condition X is 11.1 months. So 11 months, 3 days, whatever. That may not and probably does not apply to your specific case for your specific condition. So when people ask me, even really seriously ill folks who may be in the hospital nearing end of life, how long do I have? One thing that I always tell my trainees, our fellows, our residents, and our med students is, I never, ever, ever put an exact number on anything. I am not going to tell my patient that I think they have 3 months and 10 days to live, because that starts the clock. The way that we approach this is in terms of ranges. I can give people ranges. If I look at someone when I walk into the room and they are imminently dying, I can tell the family, I'm worried that time is really short, that we're looking at a matter of hours to maybe days. So all in terms of ranges, minutes to hours, hours to days, days to weeks, weeks to months, months to years. It's unsatisfying in some ways to do that. And I sometimes get, well, give it to me straight. Like, tell me what. I'm like, the reality is we don't know. And I'll be fooled on either end. We do not want folks to enter that process of serious illness with the clock hanging over their heads. Because we've been proven wrong many times. So with that said, I know this is hard to see, but I'm going to go through it. People often think about my role when I'm outside my primary care clinic. I've gotten a lot of comments. I've gotten the Death Doctor, the Grim Reaper. I've had people ask me if I brought my scythe. I get a lot of, dude, trust me, there's a lot of commentary. I was walking into a patient's room just a couple of months ago, and she was on the phone with her daughter and said, "Oh, I have to go. The Death Doctor is here." I'll take it. I'll take it. But I want to highlight the difference between hospice and palliative care and also the similarities. And I'm going to start with hospice because it's the one that most people are more familiar with. Hospice care, hospice is not a place. Hospice is no longer, in this day and age, a facility where people go. Hospice is a different way of looking at serious illness. And what that involves is a change in our focus from treating numbers in terms of treating specific disease processes. Say, an example might be, we shift from focusing on the size of a tumor in a certain cancer, and we start looking at comfort. We start looking at symptoms, pain, nausea, vomiting, anxiety, agitation, confusion. Those are all things that hospice excels at. To qualify for hospice, one needs to have a reasonable estimate of medical prognosis of 6 months or less. And that does not mean that at 6 months and 1 day, people get kicked off hospice right away. What that means is that at that 6-month mark, someone will come out and revisit the whole situation and say, has the situation changed, or do we still think it's reasonable to assume? Hospice is a specific way of taking care of people that often aligns with goals. Hospice involves, most hospice takes place in the home or in a home setting. It usually involves a nurse coming out once to twice a week, a few hours of aid care. It involves chaplain support if that's something people want, social work support, bereavement support for loved ones and families. Hospice is not 24-hour care. And trust me, I wish it were, but it is not the way it is structured now. So that's most hospice. What about folks who we just can't get comfortable at home because of symptom burden, because of agitation, because of danger to themselves or those around them? That's when we start looking at what we call inpatient palliative care units. I was talking to some of the folks here. Philadelphia used to have a lot of these. When I started here 7 years ago, there were about 12 in this area. Now there are three in the city right now. So the numbers have gone way down. They are closing. Inpatient hospice is what I would call the acute hospital of hospice. This is what happens when folks who are at home on home hospice, rather than picking up the phone and calling 911 to be brought over to Jefferson into the crazy emergency room, you call the hospice and they come out to see if they can manage something at home. If they can't, they will arrange for transport to one of these inpatient units where they have nurses who are specifically trained at end-of-life care. And I can tell you, I've worked with hospice nurses for 6 years now. They are incredible at their job. They are going to take the best possible care of you or your loved one. That I can say. You don't go into that unless you're a special person, trust me on that one. One of the questions I get about hospice a lot that I really think we need to talk about is, well, I don't want my family member to get killed by morphine. Hospice does not speed up natural processes. We work within the system, we work within things that we know are already happening. Dying is a natural part of life, dying is a natural process. Our goal in prescribing medicines is to alleviate symptoms and not to speed that up. Some people would say that we should, and that's a whole other discussion, but we do not. So that's hospice on the one side. Palliative care is this bigger umbrella. All of hospice is palliative care, but not all of palliative care is hospice. Palliative care is a field that focuses on comfort and symptom control. It focuses on values and what's important. This talk is a palliative care focused talk. To qualify to see palliative care as a physician specialty, you do not need to have a diagnosis of 6 months or less. You do not need to have that as a prognosis. You do need to have some serious illness, whether it's interstitial lung disease or a type of cancer or pretty severe heart failure. But in that role, we work alongside medical teams, sometimes who still have intent to cure, sometimes who are still undergoing tests, procedures, hospitalizations. Our goal on that side of things is to make this process as minimally uncomfortable and with maximum symptom control that we possibly can. So I think of palliative care as this big umbrella, and then hospice being a part of that. So myths about palliative and hospice, this is put out by the NIH. Here on the left with palliative care, one of the myths that people think about is that once palliative care gets involved, you cannot get treatment for any disease anymore. Not true, can be provided alongside. There's this idea that once you get palliative care, you can no longer see your primary doctor or your specialists who you have a good relationship with. Not true, we work alongside those team members. On the hospice side, we often get this idea that hospice is in some way giving up. And I hear that even from providers, that we can't treat things. The idea is not that. The idea and the reality is that we're looking at people in a different way, that we're using medications to help manage symptoms. We are not necessarily trying to cure illness at this point because we know that's not possible. But we are not in any way giving up. We in hospice are always going to keep caring for our patients. And then the other myth that we already covered is that hospice care is only provided in a hospital or hospice facility. The reality is in this country, about 80 to 85%, if not more in this area of hospice care is done at home. So that's a lot. It can be heavy, but I want to stop and take some questions and have some discussion. And then I want to actually walk people through. You don't have to fill out the 5 wishes today. That's an ambitious goal and one that, people need to think about. But I do want to be able to at least talk through what it looks like and see what folks have to say. So what questions do we have here? Yes.
You said about uploading this to Jeff.
Yep.
How do you go about doing it?
So the question is, if you take the 5 wishes, how do you upload it? So one of the ways is both Jeff and Penn use the same Epic MyChart formula software. You can go into that app and upload photos and just take a picture of each page. It takes about 5 minutes, but it'll come in as one set document.
Is the link on?
The link is not actually, it should be. But it will be, if you have a question, reach out to your provider and they can send you the link. Another question.
When you were talking about palliative care and hospice, if you're saying you're in your home and you really don't have other people to take care of you, and you need that help.
Yeah.
You're saying that
So
how does that work?
there is a middle ground. So the question was, hospice, as I said, doesn't do 24-hour care. So for some folks, having that level of care is just not possible in the home. For many folks, the ability to receive hospice follows through to nursing facilities as well. So if folks need care in a nursing home or in a long-term care facility, every single nursing home facility in this region and everywhere in the country has a contract with a hospice agency that will come in. So for some people, what that means is the hospice benefit will cover the medicines for comfort, the nurse visits for comfort, and either Medicaid or private pay out of pocket will cover room and board and the kind of day-to-day care, help going to the toilet, help cleaning up and things like that. So home hospice, inpatient unit, and somewhere in the middle is this other option. The reason I didn't separate that specifically is because honestly, I realized somebody would have that question. And 2, that's still considered home hospice, just provided in a different facility. Does that answer your question?
you know,
Not a perfect system. It's not, but we do what we can within what we've got. I'll say that. Yes,
I consider myself an intelligent person.
yeah,
But this, aside from the emotional aspects of this seems very overwhelming technically.
Yeah.
To me, is there someone or a consultant firm that you can talk to about the actual nitty gritty of doing all this, from hospice care, palliative care?
yeah. So the question is about that this can be really overwhelming to people. And the answer that is true. What I encourage, this falls in my mind under the role of primary care. So your primary care provider should feel comfortable discussing this with you and walking you through this. I bring this up in my primary care clinics, and I would do that even if I weren't a hospice and palliative doctor. So that's the kind of the first step. Palliative care helps with this for folks who are already engaged with them. So say if you have a serious illness diagnosis, they will schedule a visit with you just to review advanced care planning or just to review wishes. Does that answer some of that? Because
Now I know.
you're right, this is overwhelming. It's not the top on most people's list of things that they want to go out and do on a Wednesday morning or afternoon.
I'm just pushing the emotion.
I get it, but it's a lot to think about just technically. So I would say, if nothing else, what I encourage people to do is to look at Wish One and to review this idea of the person I would want to make decisions for me if I cannot make them myself, whoops.
So I should make an appointment with my primary care physician.
Yes, absolutely. And they should be very receptive to that. I'm thrilled when people, I would tell you my rate of return of these documents is probably around 30%. So I have to harass people, but mildly, not everyone's going to do this, and I know it, but I at least want everyone to have had the discussion. So yes. Absolutely. Question.
so, say you have done like this
Mhm.
and everything, and then it's been like several years,
Mhm.
and maybe the person like has moved out of the area.
Yep.
Or you just have not had a follow-up conversation, like, is it really advisable to like revisit and
Exactly.
say, can you still do this? And
100%. So the question was about what happens if either people change, wishes can change, thoughts can change. This document doesn't have a set expiration date, but the idea being that you should feel empowered to bring up to your providers, to bring up to your team, and to ask them for another copy of this if something changes in your life or in your relationships, or if you want to change. So there are options in here to name backups or alternates, which I do like, but sometimes that doesn't work. I've had patients who have been in the hospital and will call their power of attorney and find out they died 5 years ago. So I do encourage people to, think about it and to revisit it every couple of years.
In Pennsylvania, is there any legal difference in the location of the person who's your investigator? Doesn't matter.
So question is, in Pennsylvania, is there any difference in where your power of attorney or surrogate decision maker is located? No, it doesn't. I have called people based on this document who live in California. I've called people based on this document who live, I think farthest I've done is Russia. So even out of the country, you can technically have this. One thing that I didn't mention that I really should is that any power of attorney document, this is a big flaw in the document. Any of these documents ask you to name someone. Please, please, please tell the person you're naming them and have that discussion beforehand. No, I mean that, because your power of attorney can easily, if I call them and they had no idea, which has happened, they're like, well, I can't make that decision. So before you do that, please tell them, because they don't have to sign this. I wish I didn't have to say that part, but I do. Question.
In some states, I don't know if it's true, that if you don't have anybody to ask, that you can ask the state to appoint somebody. Have you ever heard of that?
So can it happen? Yes. Does it? No. Theoretically, there is an avenue for that. I have never seen it be successful, admittedly. So let's say there have been situations where folks will come into the hospital don't have the ability to make decisions. And at that point, it either falls to guardianship of the state, which is a legal process that can take months and months. Or if you have a provider team that's feeling particularly kind of, if there's not a lot of strife among people involved, sometimes you can get what they call the two provider consent, where two physicians will make what they consider the most appropriate medical decision. It's not a perfect system, but it is a backup so that people aren't just, remaining on ventilators forever if they're really uncomfortable, for instance. That makes sense?
Yeah.
Another question.
Is the reduction from the 17 inpatient facilities down to 3 now in the city a conscious decision by the providers, or is it something because it's being shoved off into private care?
It is, unfortunately, as in many things, I think, a feasibility issue with finances. Hospice does not pay well. We all know that. It was meant, hospice started its life as a nonprofit kind of beneficent thing, and then as usual, healthcare tries to find a way to make money out of it. It doesn't make money. That's a reality. So I think a lot of that, especially during the pandemic, with crazy visitor restrictions. Hospice is all about bringing people in. It's about having your family or friends or loved ones be present. And so the pandemic just did a number on hospice. Nurse ratios, it's a whole challenge. We are still pretty well served. I'm from Rhode Island, a population of 1.1 million. They have one total inpatient hospice unit with about 40 beds. We have 3 in the city of Philadelphia. We also have options outside the city. So I don't want people to panic and think there are no options. It's just location-wise, it's not quite as good as it used to be.
But there are private facilities like there are.
So most hospice these days is done by non-hospital based entities. So in this area, you have organizations like VITAS, which is a national group, VNA, the visiting nurses. Penn does have its own home hospice, no longer with this dedicated inpatient unit. So it's not necessarily that Jefferson has some partnership with Bayada. So it's not necessarily the hospital systems themselves. They often are entities, but it's not like I did some of my medical training in Germany where it's all small kind of homegrown systems. It's not quite like that in the US. We always find ways to complicate things. Let's put it that way. So with that said, because I have to get to clinic in about 10 minutes, but I just want to walk people through the essential parts of the 5 wishes. So for those who have it here and for those who are at home, I have enough copies that for those at home, I'll either bring them to a future doc is in, and Ed has a bunch here. I want to talk about wish 1 first, because in my mind, that's the most important one. It's the one that says, here is our medical power of attorney, if we can find one. It allows us to cross out things that we don't want our agent to do. What I encourage people to do instead of crossing out on this document is really have a deep, detailed conversation with that person and maybe even write down some of these wishes for them rather than limiting them on paper, because then it gets kind of hairy. Where does this document live is the other question I get a lot of. So I always like to have a copy of it in my office, but the original copy should be somewhere at home that is easily accessible. So keep it in a drawer. My mom has what she calls the ice file in case of emergency. So her document lives right at the top of that. There is at the back of this a convenient little wallet card that you can put in your wallet and actually make note of where your documents are so that somebody who goes to look for it doesn't have to go digging through your stuff. Make sure your healthcare provider has a copy. The second wish goes through medical treatments that people do or don't want. And again, this is where we get into that gray area of things where sometimes 5 wishes is a little better than other documents where it actually includes different situations like close to death, in a coma, permanent and severe brain damage. It also allows some room at the bottom here. So you check off what things are. And if there are other specific kind of circumstances here that you want, you put it down here. Wishes 3, 4, and 5 are where some people will say it gets a little hokey at times. I don't think so, actually. Wish 3 is about comfort-focused care and what people consider comfort. Thinking about religious or spiritual services, thinking about cool, moist cloths versus heat. It's pretty specific, but for some of my patients who tell me I'm always cold, I don't want to be putting cold towels on their faces in hospice, even if they're not able to tell me that. Wish 4 talks about how other people will treat them in serious illness. That can involve things like having a chaplain visit, having others by the side, preferences about music, pictures that may be present. Again, heavy stuff, but can be important. And then wish 5 admittedly is the one that fewest people fill out, but what do we want our loved ones to know? This involves things like, I wish to have my family and friends know that I love them. I wish for all my family and friends to make peace with each other before my death, if they can. The most important part of wish 5 is down here at the bottom, though. And it talks about memorial services. It talks about other wishes. This is where I throw in, or will even staple on, the disposition of remains. What do you want done as far as services, presentation, all of that? And then the last part of this is signature. As I said, doesn't need a notary, doesn't need a lawyer. Sign it, have 2 witnesses sign it. Shouldn't be your healthcare provider. After that, it shows you what to do as far as keeping this form at home, and having a copy with your healthcare provider. If you get admitted somewhere, like a post-acute long-term care facility, you should tell them that you have this and try to get a copy to them if possible. And then the last thing that I just want to mention briefly is people say, well, what if I want to be DNR? I do not want to be resuscitated. Does this form cover that? In the hospital, this form can help us put that in the chart. It can. In Pennsylvania and in most other states, if, say, something happens at home, a paramedic comes to the house, they are legally required to start CPR unless there is a specific document in the home. Usually I tell people, if you're seriously ill, keep this on the fridge, called an out-of-hospital DNR order. This is something that you do have to discuss with your physician because they will have to sign it as well. But that is a legally binding document for people who feel very strongly about this. So say there are folks who are going to have really serious illness who may not be on hospice, but do not want by any means to have chest compressions done if they collapse at home. That is something, again, bring it up to your doctor if you feel really strongly about that. This is a guide. It is not everything. It is not the be all end all, but it's a way to start conversations. So with that said, any final questions? Yes.
I'm already in your department, so if I go in my annual checkup,
Mm-hmm.
can I have time to say, discuss this?
You bet. Absolutely. We love it. So for anyone here who's on Medicare, especially Medicare every year will cover one visit called the annual wellness visit. The annual wellness visit is a theoretically, although, well, it should be a no copay visit that is about preventative care. Advanced care planning time is built into that visit, but you can bring this up during any visit. Even if you're already established, you can ask to talk about advanced care planning.
Thank you, doctor.
All right, everyone. I think, Mark, did you have a question out there?
Tell Ed to read the chat. There's something in there from Mary for him.
Oh, yes.
Yeah, I responded.
Oh, good. Okay. He's already responded.
Thanks, Mark.
All right, everyone. I look forward to
Thank
seeing
you
you in
very
our
much.
next one and hope that we can get some. We had a great crowd today, so thanks for coming.
See you guys.
See ya.
Thank you.